but why these measures were needed that were instilled within ArriveCan, and when the need for them started to decrease. This is important because the need for the application was predicated on the need for certain travel measures throughout the pandemic. Canada has used several travel measures, including pre and post arrival testing, quarantine of various groups, proof of vaccination when vaccinations became available. At the beginning of the pandemic, it was increasingly apparent that international travel was leading to ongoing transmission within Canada, whether it be through international flights or through the land border of the United States. And, in the first year of the pandemic, with fairly limited options to reduce transmission and subsequent healthcare utilization, and the background of ongoing local restrictions to limit transmission, the use of these travel measures did make sense. However, following the introduction of vaccinations, the data suggested a marked reduction in transmission and infection, and a significant decrease in severe complications in vaccinated individuals, marking a time where long-term sustainability with vaccinations and eventual therapeutics may have led to a rethink of pandemic measures. And particularly when Omicron emerged, many things changed. Vaccination efficacy still remained quite high with severe disease, but with 2 doses decreased significantly, with data even from Ontario suggesting very limited protection 20 plus weeks after that vaccine dose was administered, which really impacted the use of a proof of vaccination policy to limit transmission associated with travel. One could argue such a mandate was important to reduce severe disease in travelers, as the vaccines still remain an important measure for that. But we do know the distribution of severe disease is uneven, and an unvaccinated 12-year-old still presents a significant lower risk of hospitalization than a fully vaccinated 80-year-old with available boosters. Adding to this, the use of quarantine and border measures was also challenged. PCR testing, which was used earlier in the pandemic, is expensive and carries the risk of identifying low risk or asymptomatic individuals with a prior infection, as they may shed non-viable virus for weeks and even months after that infection. This became magnified in the era of Omicron, particularly when many provinces limited access to PCR testing for the general public. And so many individuals may not have been able to document their prior infection with a PCR test, thereby increasing the risk of an individual identified for random testing positive while posing no threat to the local community and having to undergo quarantine. The use of random testing with variants was important, but as a secondary benefit, but there were other methods of surveillance with the ability to do local surveillance and sequencing to improve our variant maps across the country, and global data sharing, which allowed for many countries to share this data transparently, underlying again the collaborations that allowed for us to examine variants of concern without using the international border as a method to do that. And the reality is all variants of concern eventually did reach Canada with the Omicron subvariants currently circulating. Finally, the use of quarantine in asymptomatic individuals, again in the Omicron era, in the context of wide-scale community transmission, was really of limited community benefit, recognizing that chains of transmission were far more likely to occur domestically than they were with international travel or travel over an international border. The lack of benefit was also magnified over the land border, where shorter and same-day travel, personal vehicles, a single country with very transparent access to variant data made less rationale to employ these measures at the land border. A modeling study by IATA looked at what the impact of measures would be in terms of testing and quarantine in a number of different scenarios, such as an Omicron emergence or a vaccine emergence. And across a number of different modeling scenarios, they saw a 2 to 4 day delay of the peak of infections, with largely the same peak of infections noted in local communities. So yes, these measures, if instituted appropriately and 100%, may work, but all they may do is delay the peak, not necessarily delay the amount of infections, but delay when they occur.
Dr. Chagla, thank you so much. I'm sorry, the time is up and we must move on.